Man, what a treat today. I cannot believe I get the honor of podcasting Dr. Samuel B. Lowe, DDS, MS, MAD, along with Gordon Christian, the god of dentistry, whose mom and dad were Pierre Fichard and G.V. Black, and then Dr. Oz, the real Dr. Oz, Dr. Asle T. Klemma. Let's go through them all real quick. Samuel B. Lowe received his DDS and Master's of Science degree from the University of Texas at Houston. He also completed his residency in perio at the University of Texas at Houston and received a Master's of Education from the University of Florida. He's a diplomat of the American Board of Periodontology and past president of the American Academy of Periodontology. As an associate faculty member of the LD Pankey Institute for 20 years and Professor Emeritus, University of Florida College of Dentistry. Dr. Lowe's many years' experience training dental professionals is evident in his straightforward, informative, and entertaining teaching style. Dr. Lowe was selected Dentist of the Year by the Florida Dental Association, Distinguished Alumnus by the University of Texas Dental School, and the Gordon Christian Lecture Recognition Award. He is past president of the Florida Dental Association and past ADA trustee. What a legend. Dr. Lowe, I've been a huge fan and admirers. I think you and Gordon were the first two people I asked to come on the show. Gordon, this is his fourth appearance, and this is your first appearance. You had to let Gordon come 3 times. Gordon Christian does not need an introduction. I could read it for 40 days and 40 nights. So basically, he's the founder and CEO of Practical Clinical Courses, a practicing prosthodontist in Provo, Utah. His wife, Dr. Rella, is probably the most profound microbiologist in dentistry. They're both co-founders of the nonprofit Clinicians Report Foundation, previously named CRA. My gosh, Gordon's resume is 40 miles long. Dr. Asle T. Klemma. He is a dentist at Advanced Dentistry. He's the clinical director for Heartland Dental, which is the largest dental organization in the world. They have over 900 dental offices. Their founder, Rick Workman's been on the show. I think, you're out of Schaumburg, Illinois, right?
I am, Howard, yes.
And who's my Bisco buddy been on the show from Schaumburg?
Yes.
Byung Sa.
Yeah.
And my gosh, what a legendary chemist. Well, I don't even know where to begin. So I just want to, I brought you guys on the show. Mainly I wanted you to come on the show is when I got out of school in 87, there was all kinds of periodontal procedures and we'd lay flaps and you'd send them to periodontists and all this instance. And I got to school about 87. It seems like starting in the mid-90s, people started saying, well, you don't need to do all this stuff. It's easier to treat it all with forceps and start pulling all these teeth and replacing them with implants. And after about 10 years of that, people started thinking, maybe those teeth weren't so bad after all. And now I have, the biggest concern I have is these, if you listen to podcasters, you're young. A quarter of our listeners are still in dental school. The rest are under 30. You can shoot me an email, howard@dentaltown.com, or leave a comment in the YouTube sections. But they come back, they became a dentist because their mom is. They go back into work with their mom. Her mom's placed, hundreds of implants, and they all have Peri Implantitis, around half of them. And so they're confused because when you tell grandpa that his implant where he can eat bacon cheeseburgers, he loves it, there's no pain, but then they've got 5-6 millimeter hamburger around it. And so Peri Implantitis is a big issue. So I thought, let's get you guys come on the show. So we'll start with Sam. The incidence of periodontitis continues to increase, and more so for the frequency of implant disease. We know from the most recent, just talk all things implantitis. And what does a 25-year-old need to think when she sees an implant that grandpa loves, but there's 5, 6, 7 millimeters of raw hamburger around it?
Well, you're right on target. All of us on this call have talked about this. I've had numerous conversations with Gordon about it. He mentioned to me not too long ago that when he's in front of audiences, they're asking about implantitis. It's that little dirty secret that's out there that most people don't want to admit, especially those who place implants. The American Academy of Periodontology is now admitting it. And it's hard to get the numbers, Howard, but there's no doubt we're running between around 12 to 20% of all implants placed are going to fail. I don't mean implantitis. I mean, we're probably going to lose. And there are several reasons for that. We're placing more implants. There's one that maybe our training is not where we should be. And there's one that maybe we're placing them in patients that possibly we should be keeping their teeth. I'm not suggesting something from an ethical nature, but as you know, you've been around, we have herding mentalities in dentistry, just like every other profession. The bottom line is this. When you take someone, you know, I was in practice this morning, you take someone's tooth out that they've had for 30 years, you know what they say? Thank you, Dr. Lau, for doing that. You take somebody's implant out, you better run for the hills because it's a whole different deal because you don't really have alternatives. And so this is where, you know, at some point we wanted to discuss about laser technology on where that may be not necessarily the panacea, but close to it for managing this thing. And you're going to hear me say this over and over, where we let periodontitis get to the point that we extracted a tooth. We're sometimes letting implantitis get to the point that we cannot make it reversible. So it's this whole thing, as you know, about early diagnosis. So implantitis is out there. It's not going away. It's going to get worse before it gets better. And we need to do something about it, especially in the area of the general practice.
So do you think, I'm going to go back to the cases that are failing. Of the 12 to 20% of implants are going failing, I know the first thing the 30 and under crowd's going to say is, oh, I bet those were the smokers, or they didn't brush or floss. Was it diagnosed? Was it incorrect diagnosing? Were they putting them in too old of people that smoked and drank and basically Irish people?
You know, originally we thought that nicotine usage was directly. Now the number one risk factor in the loss of an implant is placing implants. Now, you can't avoid this, but don't take risks. It's actually a history of losing teeth from severe periodontitis is the number one risk factor. The rest doesn't help, but the bottom line is we're also taking chances placing implants that we didn't do before. The reason that we had such a great track record in the past is that, you know, we placed implants with a 30 millimeter wide, 30 millimeter height, 35-year-old male in the position of number 19. You could go to Ace Hardware, get a stainless steel screw, blindfolded, put it in backwards, and it would probably work. That's not what we're doing now. Plus, you know, I just want to reinforce there has to do something also with training. And let's face it, we're reaching a point now that unless you have a CBCT and a surgical guide, if it fails from a litigation standpoint, you should have a good attorney. So I agree about the risk factors in the past, but there is a thing of just not placing them correctly, them sitting around for 5 years, and then when they go south, we think it's because of implantitis. It may have been the original positioning of them. So it's multifactorial.
Who's next, Dr. Oz or God?
Oh, God's always first.
You would all be interested in hearing what I'm going to say. As you know, we provide many hands-on courses in Utah from people who are well-known in the profession in all areas. And we elected last about January to institute one on rescuing implants. Usually a course takes several months to fill up. That one was filled up in a couple of weeks, and we had to start turning people away. John Suzuki and I provide that course. And in doing so, well, Kevin Suzuki too, John's son. In doing that course, it was very interesting to see all the group that were in the course had done implants for some years. It was a fairly mature group compared to what we usually get. We usually get about half young dentists up to 5 years out of school. These are hands-on courses. We have models where they are simulated failures. We go through the conventional orientation of implant salvage, which is basically stage one. It should be done by any general dentist. It's basically lavage and scaling, root planing, etc. The conventional I'm talking about, not laser. And then you jump up one level, and if there's enough loss of bone and obvious denudation of a number of the threads, you pretty well got to lay a flap with a conventional technique, as Sam knows better than I. And when you do that, then you've got to clean the miserable thing off with a wire brush or glycine or whatever, and then suture it back, sprinkle some owl feathers, pray a little bit, and hope that it's satisfied. In surveys of periodontists even, we're seeing only about a 50% chance of recovery with the conventional technique. In that course, we also add an addendum of the potential of laser, which I'm sure you want to get into later. But the disease is there. I agree completely with what Sam just said about the various causes. The chronic ongoing periodontitis is one of the majors. Of course, smoking is. I'm seeing people take large cases of restorations off a articulator, plunk them in the mouth, cement them, and never touch the occlusion. Occlusal load is a major failure situation. And long angulation is all on four frenzy that everybody's getting into now. Often gets them at 45-degree angles. The photoelastic stress analysis shows that the negativity of that. We're in about 20 factors I can identify right off the top of my head that would be influential in predicting failure. And let's not throw out osteoporosis. You know, many people placing implants are in the 50s and 60s, and many will have a T-score of over 2. Bottom line is they're going to fail too. You stick them in where the bone is inadequate. And I asked this group, who knows their T-score? I had one guy in the group who knew their own personal T-score. Bottom line is there's so many factors. Rella was asked, my wife, to do the micro on it, and she turned it down because she said there's so many factors, we'll all be dead before we can evaluate enough of them to get a really good answer. Bottom line, it's here. We got to do something about it.
So you said John Suzuki taught that course with you, and you said his son helped.
Yeah, his son Kevin is a periodontist, about 10 years out of school. He's in Seattle. Very fine person. Yes.
One of the things I want to go to just the finance side of it. A lot of dentists took on an associate, and the number one associate turnover is, you know, that they go work at these big DSOs that they only last about a year, and the only thing that's really keeping associates to stay maybe 2 years is if you give them a lot of CE. And a lot of these people want to learn implants, so they put a lot of money into these young kids to place implants. They place 4 or 5 implants, then they job hop after a year or two, and then over the next 5 years, they got to pay $5,000-$6,000 to have every one of these 5 implants replaced and redone by a periodontist. And I just lectured to a DSO group here in Scottsdale a couple weeks ago, and they're to the point where they don't want anybody even placing implants anymore unless they're a board-certified periodontist, and some of them have got to that point with endo. They're like, yeah, you let these kids come out of school and they do their first 10 molar root canals on your patients, and then they go take a job somewhere else, and guess who's going to have to send every one of them to have a retreat? So do you think that one of the problems with these failed root canals is that I mean, if I was going to get an implant done, I wouldn't want to go to somebody who just did their first 25 implants. I'd want someone who's done 1,000. Is that part of it? Or is it still, you said the number one risk factor was having a history of losing teeth from periodontal disease. Is high up on that list undertrained young kids?
Laws, you're involved with that. Tell him.
Well, I do deal with a lot with that, Howard.
And by the way, you're with Heartland, which keeps the associates the longest. Heartland and Facebook are keeping their millennials about 2 years, whereas the rest of thing, Amazon, Netflix, Apple, Google, like Google, they give them every perk in the world, and their average millennial stays 1 year. Amazon has the shortest, it's about a year. And when I look at dentists, when they come out of school, when they get an associate job, it doesn't matter if it's private practice or whoever, their average associateship job is a year. But you, Heartland, keep them the longest in dentistry, just like Facebook keeps them the longest in the tech industry. And everyone that I've ever talked to from Heartland say they're staying on with Heartland because of all the opportunities of continuing education, like learning how to place implants.
Yeah, there's no question about that. We really trained the dentist, and everyone graduated. Dr. Christensen, obviously, and Dr. Lowe graduated before Howard and I, but I personally believe, and I've spoken to Dr. Lowe about this, they don't get a lot of training in endodontics like we did. I mean, we have to do about 10 molar endos. We have to do probably 30 gold foils, 10, cast crowns that we had to do ourselves. And I think the educational part, we see dentists coming out that have never done endo, never extracted a tooth except hanging there from periodontal disease. So I think the education of the young dentist is now being put into the private sector much more than it was even 15 or 20 years ago. There's no question about that.
As old as I am, I keep teaching because what I see in hands-on courses is unbelievable. And you just said it. I'm seeing kids who have done 2 crowns getting out of school, watch the denture being done. I even hit one kid recently who did 1 canal on a 3-canal tooth, and 2 other kids did the other 2 canals, and they're a dentist just like you and me.
Yeah.
So is Heartland to the point now where they're thinking that, you know what, we're just going to only let endodontists do endo and periodontists place implants? Are they approaching that, or is that not even on the board?
Well, I don't want to speak for Heartland. I just know our educational system, Howard, is the world class. We're actually putting more money and more time into educating them. We've got a mentoring system now that is on board that is second to none, that we can just about guarantee that at the end of the year that they'll be performing root canals at a level that none of their, I shouldn't say none, but very few of their contemporaries that don't go into extra continuing education will not be able to do what they're doing. So we're putting a lot of resources. We're basically doubling down our resources in continuing education because they need it, pure and simple.
Howard, I strongly believe that it's not postgraduate, post-graduation, CE, hands-on is necessary. We have a series of 13 courses, 26 days, and it's almost embarrassing to me to say, now they're all name brand people, that they probably get a better clinical education than dental school in 26 days, if we take the average school. Now, there's some outstanding good schools, and there's some outstandingly unbelievable bad schools. So you get out of one of those mediocre or bad schools, they have to go post-graduation CE to even know what to do.
Come on, Gordon, make the news. Who's the worst dental school in America? Come on, you got 50, 60.
I'm not going to tell you. I don't need any more dang lawsuits.
Okay, just text it to me, then I'll say it. I'll tell you what, when I got out of school, that was the first thing I did is I went up to Provo. I took at least 2 years off Gordon's life. I went up there with Mike Totola. We sat in the front row of every course every month for a year. And I remember every time he'd walk in there and he'd see us for like the 10th time, he'd look at us like, oh my God. You could just, oh my God, those were the best days ever. I love that. Shout out to Totola. So I'm confused. I'm really confused about this. 1900, healthcare is only 1% of the GDP. There's no specialties. One doctor does it all. By 2000, healthcare is 14% of the GDP. The MDs have 58 specialties. We have 9. Now it's almost 2020. We're up to 17% of the GDP. There's 40,000 doctor journals every single month in the world. You couldn't keep it up on And I see these dentists that they want to do it all. They want to place implants. They want to do root canals. They want to do Invisalign, pediatric dentistry. They want to do it all. And history has showed us that specialization is taking place. And you're not going to go to GM and say, hey, why don't you make refrigerators and washers and dryers? So what do you think about the modern day love affair about this super dentist, this mythical super dentist that's just going to do everything? Does that even work?
Well, I want to give you a counter with that. And that is, patients at this point expect everything to be done in one place. And from a competitive standpoint, I'm with you from the standpoint of standardization and bringing the level up. But the bottom line is, patients expect everything to be done in one place. So it's not just about the dentist trying to learn everything, the pressure that's being put on them, because when I do a CE course, I ask the audience, does the patient ask you, doctor, I know you can do it. You place those 8 veneers. I know you can extract those wisdom teeth on my daughter, with the roots wrapped around the invalvular nerve. I know you can do it. So there's a significant amount of pressure that's being placed on these practitioners. So let me bring something forward. And this is also something that Gordon and I have talked about. Let's take periodontitis. Periodontitis, 98% of all periodontitis is managed by a hygienist in a dental practice. We are still losing teeth because of that. Now, part of that is because the general dentist does not know how to do moderate to severe cases. And part of that is the perception of doing periodontal surgery. For the most part, if you go on YouTube and look at periodontal surgery, it'll scare the heck out of you. And in fact, I was in the clinic this afternoon, and someone came in with their daughter. We were doing a mucogingival procedure. The daughter, who's 15, had already been on YouTube and saw a mucogingival surgery and was freaking out before we could even get her in the chair. So the bottom line is we have transfer. My position, and I do believe that so I want to just connect the dots for you. Gordon and I believe that it's time for general practitioners to start doing some periodontal therapy besides non-surgical so that we can save some teeth. And to do that, it can't be done with a blade, and that's where this laser comes in. And I would like Oz to speak to that, because Oz is a prime example of a general practitioner who I believe did periodontal surgery well, but now has done a significant number of periodontal surgeries with a minimally invasive laser. Then I'll go one step further.
Was it a diode or a CO2?
No, it's a full-blown erbium all-tissue laser. That's the only laser that it has to be an all-tissue laser, or you're going to burn the teeth, burn the implants. And he's acquired that expertise with the training, he and his other colleagues at Heartland, to make this happen. So my point is this. It's what I call total solution. Everyone wins. There are cases, Oz is smart enough. There are cases that he's not going to touch. But there are going to be a heck of a lot more cases that he is going to touch now, because those patients, if he didn't touch them, Howard, you know what they'd do? They'd leave. They'd leave, go down the street, probably have their teeth extracted, probably have the implants that were touching. And so I'd go one step further, the same thing with implantitis. The only thing I can see right now to really manage an implant surface is going to be a laser, and it has to be an erbium laser, but it has to be done when you first start smelling it at the first thread, instead of waiting till the sucker is it's what I call respiratory periodontitis. Is when you breathe, the implants and teeth move back and forth. So it's time to change. And to me, that's what this podcast is all about. That's why I wanted it to be with your venue. That's why I wanted Gordon. That's why I wanted the practicality of Oz, because it's time to make a change so that people can keep their teeth. And if it's implants, keep their implants.
Okay. Well, go ahead. Go ahead, please.
I'll add a comment to that. Often I ask, well, I've worked over my career with some name brand periodontists, including Robert Schallhorn, who I've practiced with 8 years while we started at the University of Colorado, George Bailey here, and Suzuki, many others. So I've always been heavily involved with periodontists, even though I'm a prosthodontist. I do quite a bit of periodontal surgery, and I've placed implants now for 36 years. My original course was from Brandemark himself. So I have kind of a fetish about this. I often ask in a course, especially when a lot of hygienists are there and dentists, I'll say, how many of you dentists have done how many of you have done 10 periodontal surgeries in the last 12 months? Get a group of 300, 400, all have 3 or 4 hands that go up. They do not know how, nor do they want to lay a flap. Now, doing conventional implant salvage, you have to lay a flap in a moderate case or one that's getting well along. But in the earlier stages of Peri Implantitis, use of an erbium laser does not require the use of a flap, because the energy now is not just emitted in a straight line. It comes out peripherally, and although you can't see it, once you've done it a few times, you get the feel of it, and you rotate it around whatever part of the implant is not really has bone over it anymore, and that laser pops the garbage off the threads. And then you follow up with conservative techniques and grafting if necessary. But the bottom line is there isn't a necessity to lay a flap if they get it early enough. Sam, how do you feel about that?
Well, that's exactly, and we have the science to show that. But you're right. If it's more than 20%, you got to reflect a flap to see it. But less than 20%. But you know what we've been doing is the same thing we did, and sorry for venting, but it's the same thing we did with periodontitis. You know what we're doing with implantitis? We're watching it. So then it goes to the next thread, and it's exponential. And we've got to catch it when we see that very first bone loss. That's or actually what we should be doing is having our dental hygienists. And this is, my partiality to glycine air polishing. We need to be doing something to prevent these implants from being lost. But I'm with Gordon. Why don't we give Oz the tools for him to be able to save teeth without a flap? So Oz, you've done several of them. Your opinion of where we are right now with erbium lasers?
Okay, but I'm just for the viewer. They're still. I'm confused. They're confused. You're saying an erbium laser hard tissue. Is this something I can drill? Work on enamel for? If
it can do everything, but its expertise is in bone, root, soft tissue, periopathology, implant pathology. That's where we're going. Howard,
which laser are you talking about? What's the name brand number of the laser you're talking about?
BioLace water lace technology.
Okay, so it's the BioLace water lace you're talking about.
Yes.
Oh, okay. All right, got you.
Varieties of it, and they've been around now. Well, the Express is relatively new. The older one has been around for quite a while, but they are both erbium, and they're all tissue lasers.
Okay, Dr. Oz, what did you want to say?
Yeah, I'll just tell you a little bit. I'm a general dentist, Howard, but I do like doing, I'm an endodontic nut. I love endo. So don't ever say dentists can't do endo, because it is so fantastic.
I love it too.
Yeah. So when I got out of school, I was fortunate enough to have some friends that went to specialty schools. One of them was periodontics, and he would come out every Friday, and all we'd do is perio. I got out a little bit before you, Howard, and we would lay flaps. He would do one side, I would do the other. He would take all the money, but I didn't care because I was learning. So I spent 2 years doing this with him. So the first 10 years of my practice, every Friday, it's all I do is perio surgery. We'd line them up for Friday, every one of them. And then you remember the Kai's method came out and things like that. And I started thinking, as you said perfectly about a half hour ago, more conservative methods came around. And I started seeing these long roots and these people, had big spaces between their teeth. And I started saying to myself, you know what? I just don't know if this is the best way to treat my patients. To me, when I look back at it now, it was barbaric when I took a 15 blade and cut the tissue and made the distal wedges and it really was not a pretty sight to see. So I love endo, but I want to keep my patients healthy. And we just happened to, we knew Sam, personally through BioLays, and we've been to many of his lectures and such. Great lecture, as you know. And we just got together, and as just a family dentist, I said, could we do a little program? Let's take 4 dentists, and let's see how they do. 4 general dentists. And let's do a little, pilot project. I don't want to call it a study because we didn't study anything. We did a little pilot project. And Sam said, okay, let me work on that. And we came up with a couple of meetings, and we said, okay, we're going to take 4 really high quality doctors that can do surgery, and we're going to utilize this laser and see what we think. And I was kind of excited because I'm thinking, well, I've got the greatest hygiene department in the world. I'm not going to have anything in there. I might do some frenectomies, things like that. But I was really challenged by Dr. Lau to really sit down, and he really asked me to probe certain areas on my patients. He said between tooth number 2 and 3, 14, 15, 18, 19, 30, 31. He goes, really sit down yourself. Don't let just your hygienist do it. Sit down yourself and take a look at these. And I'd sit down, I get a little bleeding in a 5 millimeter pocket. And what you said before, we'd watch those implants. Well, I didn't want to send my patients to the periodontist for a 5 millimeter pocket. And I really didn't want to use a blade on them. I really didn't want to do that. So lo and behold, what happened through a 6-month period of time is those 5 millimeter pockets that I was watching, maybe, trying some Arrestin, which is, I think works fine sometimes in some areas, but not always. I would anesthetize the patient. I'd have the BioLays, water-lays ready. And lo and behold, those 5 millimeter pockets were actually 7 millimeter pockets that some of them actually had exudate on. And this is a hygiene program that I was extremely proud of, and I'm still very proud of them. But I let it go. I let it lapse a little bit. I'd watch those 5 millimeters. I'd watch those 4 that were bleeding. And I ended up doing, I don't know, Sam might know numbers better than I do, 40 or 50 quadrants of surgery in 5 months. And not full quadrant, not up to tooth number 7 or 8 or something, but I did a lot of 2, 3, 4s, 13, 14, 15. And the great thing about it was I was able to do it like painlessly, because the postoperative pain was unbelievably less than it was when I did it with the blade. We also get some photobiomodulation effect from the laser, I believe. So the healing, as soon as you're actually making the probings with the laser, you're actually starting to get the healing process, which is, that's scientifically and that's known. That's not guesswork. But it really turned a lot of heads for us, because we're thinking, we're good clinicians. How can we miss this much? And what's someone that's not as careful as we are, what's going on in their practice? So that really started us thinking about, hey, we gotta change our thinking about this a little bit. And also, not to cut out our periodontists, I'm going to tell you, my periodontist got more business from me after this little pilot project, because I started diagnosing more, and I found things, you're absolutely right, I didn't want to do. Better he does these than me. But I'm going to tell you, it's teachable, trainable. Dr. Lau can talk to it in greater detail, but he calls it the perio repair system. And it is wonderful. I mean, I teach lasers, a diode laser. I don't want to say I'm an erbium expert, but he's got it on a touchpad. All you do is touch from step to step to step to step, which to me just made it so easy, Howard. Again, I'm not a techie, but it made it a simple process for a general dentist.
Well, I wanted to sit there and say I would give anything if my buddy Fred Margolis was here today. He was, I called his podcast Laser, the Star Wars of Laser Pediatric Dentists. He was the first dentist who really took a hard tissue laser to pediatric, and he always said, my gosh, the time it takes you to get a child numb, I could have taken a hard tissue laser and just done the whole filling. But anyway, what you guys want to say anything about Fred Margolis before we continue on perio?
Fred, we miss him. He was incredible. He, in his own way of being very humble and sharing, we really missed him. He was a pioneer in pushing lasers, especially in pediatric dentistry. So I really appreciate you bringing him up.
And so when you're talking about BioLace all tissue, if they actually get this machine, though, they can do what Fred Margolis was doing on enamel, and they can do it on perio, right? And then is that correct?
Yes, that is correct. It's more technique sensitive. But you know, Howard, where I go with this, it's called value added procedures. And if someone is not doing a particular procedure and you add that to, and they're trained, then to me, that moves the quality of the practice. Not taking anything away from using these lasers for restorative dentistry, but there is just so much more opportunity in using them for periodontics, implant procedures, frenectomy, newborn frenectomy with laser is an incredible opportunity, with 10% of all babies born having lactation issues. So there's just significant opportunities out there. And that's what Heartland found.
Yeah, one of the top 3 courses out of 400 on Dental Town is pediatric dentist doing one on tongue-tied, because it just probably our generation probably had a lot of them, but they didn't. Moms didn't know anything. But I get another clarity. When you go to biolace.com and you type in Waterlace, there's a Waterlace Express and a Waterlace I+. Which one are you guys talking about?
Well, the I+ is a powerful device that works on not only what we've been discussing, but also for your class 1 and class 2s. The Express laser, which is what Oz wanted, is also what Gordon has, is a laser that you could do class 1, class 2s, but probably not as fast, but you can do every single thing else. Plus, as Oz mentioned, it's all on a touch screen, a Samsung tablet that runs it. But more importantly, that laser is 27 pounds. That will fit in the back seat of your car if you had more than one office. So it's the newest of the news from BioLace. The portability of it is attractive to many, but all of the procedures, with the exception of doing class 1, class 2s fast, can be done with the Express laser.
And I just want to make sure everybody knows one thing. This is not an advertisement for BioLace. Don't even go there. These guys aren't giving me any money. Gordon won't even buy me a beer. And so these guys are just talking from their heart. But and I also want to say one thing on the price of a laser. You guys, there's 3 numbers. There's a statement of income. That's your profit and loss. That's a report for third-party tax collectors like the IRS. Maybe you're publicly traded. It's for the SEC. There's a balance sheet. What balances the cost versus the equity I paid in versus the liability I owe. You don't manage a business with a balance sheet. You only use a balance sheet when you're trying to get other people's money or you're trying to split up your own money in a divorce. You only manage off a statement of cash flow. And so I don't care about if this laser costs $1,000, $10,000, $100,000. I want to know what is the monthly payment in this month, because I pay my bills monthly. So if I have to pay this laser company, say I have to pay them $1,000 a month, I need to know what can I do to charge out and bill $1,000. So on that exact question, who wants to take, what is the lease payment a month? And what are some examples of procedure I can do? Like, what is the monthly lease payment for Waterlease Express or Waterlease I+? Does anybody know?
Yeah, I know. You could, the payment on an Express laser would probably be around $700 to $800 a month. The payment to you on one quadrant of periodontal surgery with the respective code is about $1,200 to $1,400. One frenectomy is $500. If you did 2 frenectomies a month, you would pay for it. So in my mind, I'm right there with you. It's called value added benefit with the return on the investment, or guess what? It's going to end up in your closet like everything else.
Howard, let me make a statement on that. I've played with laser, believe it or not, since the early 60s, and been off and on. As these hard tissue lasers evolved, and there are several out there now, we've worked over the last while, and since we don't want to make this a BioLase commercial, we've worked with the Solia, Vitana, and the BioLase. And there are about 15 procedures that each one of the companies promote. And as you just said, Sam, if you were to take those 15, about half of them can be done with other modalities. On the other hand, to do them with a laser is a change in the overall office orientation. You've got a blade, of course, for $1.50. You've got a burr for $1.50. You've got a laser for whatever, a significant amount of money. Will it add to the practice? And the answer is yes. There's somewhat of a mystique about laser. I think it comes from LASIK surgery, because they see that in every newspaper they pick up. And the general public would think, well, it's good on eyeballs, it must be good on teeth. So there's already a sales pitch that you don't even have to make. We're going to use a laser. And, well, going back to Margolis and the child, there's an area where obviously you can cut a prep. They just timed me, and it happened to be with the Solia laser. It took me 45 seconds to cut a small class. It took me 2 minutes to do, but there was no anesthetic, as one of you guys said. And therefore, the procedure went rapidly. Of course, you're changing the energy. You start slower. That's why it takes a little longer. You start slower until the mind is capable of tolerating the slight feeling there is. And then once you get it up to the level of energy where it's potent enough, you cut relatively fast. So if you take, as I said, those 15 procedures, I'd say half of them you could do with something else. But the mystique of laser, the less pain that laser has, are value-added sort of things, as Sam has said. And there are good studies to show that the gross revenue of dentists using these major lasers is rapidly, once they learn how to use its various other orientations than just cutting teeth. If I just had to cut teeth with laser, I'll be candid and say I'd probably use a burr. If that was the only thing it did. But that isn't the only thing it does. It does so many things that could not. Well, let's just take, I have a piece of tissue growing under a bar and clip thing. If I use an electrosurgery on it, I basically burn the implants right out of the mouth. If a person's wearing a pacemaker, I can't do that with typical kinds of electrosurgery and other modalities. There are just quite a few things once you have a laser that you figure out, I couldn't do that with other things without really stretching it or having blood all over everything. So we have to look a little broader than we have in the past. And I've told Sam before, I think implant salvage will probably salvage lasers. They've been around for 60 or 70 years, so it isn't like they're new. But now there's a new need, and that new need may allow relatively uneducated dentists to do a non-flap preventive sort of a procedure early on when that implant's only about a 1 or 2 or 3 threads denuded. So I think we have a salvage coming.
Dr. Oz, Sam said that Fred Margolis was a humble man, but I imagine anybody who lives in Chicago and lived under the White Sox for all those years, you just have to be humble. But I was wondering, you went to Loyola too, and was Loyola a big part of this? I mean, you graduated from Loyola Dental School in 1982, started practicing in Chicago, and then Loyola closed down in what did they close down? 93. On their 70th year anniversary. But you and Margolis, both Chicago people, was Loyola big into lasers? Is there a laser foundation from Loyola?
No, they were not. Absolutely not. I knew Fred. I certainly can't say I was a good close friend of his. Attended several of his lectures. Tremendous man. But no correlation.
Was he a Chicago Cubs fan?
He was a North Side guy. So I would tend to think he was a Cubs fan.
Sam, that's why he's humble. They just lower their expectations to zero. The only team worse than that is the Minnesota Twins, but we won't go there. We're not going to go that low on this show. But
one thing I will just add again, I have no. I'm not hired by BioLaser or anything. Sam just asked me to be on this because we did that pilot project, just so you know. But I think at 7 months, I had paid for my laser with using the water laser by the procedures I had performed. My ROI, which I go by, the ROI was tremendous. So I can just speak for myself, and I have a very nice practice, again, where I thought the periodontal tissue was really, really good everywhere. I mean, I found enough, and, I'm happy for my patients, not for myself. I'm happy for them because I was doing them a disservice by not addressing that 4 millimeter bleeding, 5 millimeter pocket. So I did enough surgery, and I'm not even call it surgery, even though you have to legally. I think by 7 months, I had done enough work to pay for my laser. So just a little tidbit there on ROI on that water laser.
Sam, I hate to be redundant, but I am I'm the one representing my listeners. A lot of them, I know, they're thinking, well, I heard just get a diode laser. It's a lot cheaper. Remember, a quarter of my listeners are still in dental kindergarten school. So, what would you say to a sophomore in dental school who says, I thought the cheapest one was a diode laser. What would you say to that kid?
A diode is a very acceptable laser if you're doing soft tissue as troughing. To me, a diode laser is like if I wanted to go, I'm in Florida now, if I wanted to go up to Atlanta, I could go with a smart car or I'd go in a Tesla. The diode is the smart car. The erbium is the Tesla. Number two, first of all, so there's a major difference in speed. A diode works off of thermal, and we all know that. And actually, unfortunately, and Gordon has mentioned this before in his seminars, and he's right on target. Many folks use a diode as if it was an electrosurge. They would be better off if they just used an electrosurge. An erbium is different. An erbium laser can actually remove calculus, remove the smear layer so that we can get attachment. It can degranulate, and you can never touch. You can't really effectively even do second stage implant uncovery with a diode. Someone came up to me, I was lecturing last week. He had tears in his eyes, and he says, I now know why I've been losing some implants. I've been using my diode laser to do second stage uncovery. Mm-hmm. And I said, well, what settings were you using? He said, well, I was using what they told me, not the manufacturer, but one of his friends, which was like 2 watts, continuous wave initiated tip, which is an electrosurge. So, yeah. So the implants are falling out. So I don't want to take anything away from a diode, but really There's no other way to saying it, Howard. It's a poor man's laser. Sorry.
And I also want to ask you, I went through all continuums of the Pankey Institute in Key Biscayne. You've been faculty there for a long time. I think most people would agree it's probably the most prestigious name brand dental institute. How's the? Are you still at the Pankey Institute? How are they doing? What's new at the Pankey?
They're doing well. One of the best things that we ever did was hiring Lee Brady. Lee Brady has changed everything for us. First of all, she represents where dentistry is going. And our classes are now fuller than they were before. She and I are talking. I'm about ready to put a laser in her practice in Arizona. But she has turned it around to where now Pankey is back where it was. And I've always felt, it's been a privilege to, Dr. Pankey was one of my mentors. I still use his euphemisms constantly in my lectures. But though, Howard, let's go back to the millennials, though, and let's just be factual. Millennials don't do CE like Xers and baby boomers did. You have to go to them. And I'm not trying to typecast all of millennials, but it's the same reason why you're not going to see millennials own practices in the future. We thought that millennials would try a group practice and then say, hey, I don't like it. I'm going to go on my own. No, what we're finding are millennials don't want to own a practice. Now, please, anyone on this call, I'm not throwing every single millennial in there, but I know our dental school class, of the 94 that came out, I think 2 set up their own practice. 92 did something else. And they like that. They like working in groups. We liked being independent. They want to be in groups. In fact, they freak out if they think they're going to go practice by themselves.
I know Dr. Oz even lectures don't practice alone. He always says find 2 mentors and don't practice alone. I hired my first associate right out of school, and I was so dumb. He was as young as I am. We both had just graduated like an hour ago because I wanted a buddy. I wasn't smart enough to know I should have had a mentor. I just knew I didn't want to be alone.
That's right. And that's one of the things that I do kudos to Heartland for. I knew Heartland, but when we introduced lasers, I got to know them more. And Oz is one of those mentors. It is amazing how much hand-holding they do on these practitioners. I mean, Oz, you spend a great deal of your week looking at their cases, talking with them by phone. So yes, you know what this is about? I'm not going to get on this thing about dental education because I could. Part of it has to do with standards and et cetera. I would be the first to tell you we need to do some improvements. But the comment that they leave there probably not where they should be, thank goodness there are the Heartlands out there that can take these folks and give them at least the practicality of education.
Mm-hmm.
Yeah, no, thank you, Sam. And that's absolutely true. When I got out, I would see Dr. Christensen. I would go see Dr. Dawson. Harold Chevelle was really one of my main mentors. I don't know if you know him, but my gosh, now at least, even if they aren't as thoroughly trained as we are, a lot of them still really want to be good. And we like being there to help them become better. It's all about education. It's a lifetime. It's an art. Dentistry is an art. And you just look at Dr. Christensen, Dr. Lau. You can't find 2 better examples than that. They're still working at their craft, still getting, I don't know about better, but still getting more educated. And that's really the idea,
We talked about Fred Margolis, the Star Wars of pediatric dentistry. You just mentioned Dawson. We just lost Peter Dawson this year, 1930 to 2019. You guys want to say any words to what Peter Dawson meant to you?
Peter Dawson was a very good friend of mine. We were together in the Academy of Aesthetic Dentistry for many, many years. I have the greatest respect for him and his influence in the profession, particularly in occlusion. We treat three major diseases in dentistry. We over-treat caries. Every little pothole is treated. We know that perio exists, but we can barely spell it, even though most have had a good course. And we can't even spell occlusion. So Dawson brought occlusion out of the closet and started to make it pragmatic, started to make it at a point where it would actually generate a little money, and made it a little more of a science. It's still not a science, it's semi-witchcraft. But in the meantime, Pete was the person who did that. He and I developed a few things together, and there aren't very many people who have done as much as Pete, even close to what Pete did, including. Can't say enough good about him.
Sam, what do you think? You're at the Pankey Institute. A lot of people don't realize the Pankey Institute never competed with the Dawson Center, did they?
It's always been synergistic, even though we were both, we're both in the state of Florida. Hardcore occlusion, it was Dawson. Comprehensive treatment planning and relationship building, it's Pankey, and they still coexist. The work that John Cranham is doing with Dawson is extremely positive, taking it in that direction. But one of the issues, I'll give you a very interesting observation because I am at the dental school today. All of us on this call, you remember waxing crowns.
Yes.
Remember, even some of us go back to different colors of wax.
Absolutely.
Remember the little cones that we were doing and all that stuff we were doing? Well, we were doing that because we were the lab people, because we did everything, right?
Right.
We had the sprues, you name it. Now, in our dental schools, all the lab work is sent out, and our dental students don't do lab work. That's neither here nor there, but you and I learned occlusion waxing. Unfortunately, the dental student leaving has never really waxed anything. So therefore, from that standpoint, they are totally not in the occlusal vein. So it makes it even more that they need to go to Pankey, or they need to go to Dr. Christensen's courses, or they need to go to Dawson, or they need to spend time with Oz. And I want to say one thing that Gordon mentioned. One of the areas that we are going to find out eventually with implantitis is going to be occlusion. You watch. Somebody is going to do the right study to demonstrate that bone is not concrete, that it's viable. But you know what happened? See, we get away with a lot because of a periodontal ligament. You don't have a periodontal ligament in implants. And that's when you begin to see screw fractures, decementation. I am convinced that you better know occlusion or you should not restore implants.
And I'll add something to that, Sam. If a person is placing implants, and now it's around 10% of general dentists placing implants, I'll be in Israel next week. It's about 80% there. We're way behind other countries. But with that many people placing implants, I strongly believe it's much like an auto mechanic who can't fix a motor. A person who is placing implants should be able to resurrect them. And that's a lot of dentists. That's at least 20,000 dentists in the U.S. placing implants. And if they have to refer that, that's like the auto mechanic saying, I don't know how to fix a carburetor, I'm going to send you down the street. They need to know how to salvage them. And laser has a potential there.
Okay, I want to, the millennials, they love Shark Tank. If they're going to have their own business, they love Shark Tank. And I want to, if you were on Shark Tank and you were on recommending this BioLace, Waterlace, Mr. Wonderful would say, well, who's your major competition? So I guess that would be Fotana. So if a young kid was asked you, well, what's the difference between the Fotana laser and the Waterlace? What would you guys say?
Quite a bit. Sam, do you want to do that?
Well, we could get down into the granular, Howard. The erbium YAG is a laser. The erbium, when it sees water, it immediately stops. The erbium chromium YSGG, when it sees water, it's absorbed. Personally, we like, because we are working with soft tissue, we are working with hard tissue, we would like a better depth of penetration. So that is the difference between an erbium YAG and an erbium chromium YSGG. The other parts are again, like the icing on the cake. It has to do with the training. It has to do with the follow-up. It has to do with the possibility, by the way, this just happened in the last 2 weeks. Biolase secured a FDA clearance for removing crowns and veneers, zirconium crowns, off of teeth. And we are the only company in the world that does that. And that is incredible when you can take a veneer off in 30 seconds with a laser. And the reason it works is because the energy goes through the zirconium, finds the water in the resin, causes micro explosions, and literally pops that veneer off as a whole. So there are some smaller differences, but you know really what this is, and I'm going to take off a Biolase hat. You know what the number one competitor is for any laser company? It's dentists that have not appreciated getting out of their own way and start looking at laser technology, because our patients are expected. They don't want to hurt. They want minimally invasive. And as Gordon says, this is about LASIK. You know, I'll bet you that if you and I interviewed ophthalmologists 25 years ago and said, hey, we have lasers, you know what I think they would have said? Exactly what many dentists are saying today. And I would never have my eyeball ever worked on without an ophthalmologist that didn't have a laser. This is where I know this is going, because this is what patients expect, and this is where the value added is going to occur.
Okay, so I got a follow-up question. So you're recommending this Biolase water lace, and I know someone's listening to this saying, well, what if maybe I should do Lanap instead? Compare water lace to Lanap.
There are significant similarities because, Howard, as a periodontist, there are cardinal rules in anything we do that you can never try to violate. There is one difference. The Periolase is a soft tissue laser. It is not an all tissue laser. It cannot remove the smear layer. I don't want to overlook the smear layer. Unless you open up those dentinotubules, you're not going to get the kind of attachment we're talking about. And I could probably buy 2 or 3 express lasers for the cost of an IndiYAG laser.
Right. Okay, another question. When I tell you this statistics, you're not even going to believe me. But at the Cologne meeting last year, there were 400 different dental implant manufacturers. 400. Yes. And you won't even believe this. Over half of them are just from the country of Italy alone. But the question is, do you think some implants have surfaces more prone to peri implantitis than others?
Well, that is, you like to be candid, Howard. Here we go. Implant companies are in denial that there is implantitis. Many people who place implants, including my colleagues and my oral surgeon brother, are in denial that there is implantitis. It's only natural. Why would I admit failure when it's my business? However, we have done studies. Implant surfaces are different. They're very different. And the interaction of attempting to detoxify them are also very different. Now, this is somewhat controversial to a certain degree, but when you talk about detoxifying or decontaminating an implant surface, you got to tell me exactly what you mean by that. because I can take a cotton pellet filled with chlorhexidine and pretty well do a number on most implant surfaces. That's not what this is about. This is getting towards corrosion. This is getting towards titanium oxide. This is now in referee journals. And this is where the laser comes in to make that surface like it was when it came out of the package.
She just wants to know. She just wants to know, look, I'm coming out of school. I want to learn implants. Just give me the name of the system. If you were 25 and you had $285,000 student loans, and I mean, because when she goes to her periodontist and oral surgeon, they usually have 5 different systems. She doesn't want to buy 5 different systems.
Correct.
If she wants to buy one system, what would you tell her?
I can tell. Well, I'm a Straumann guy. I've been a Straumann guy. I love the SLA surface. It's done me well. I know every single article ever written on it. I love them as a company. They've got, and someone asked me when I was placing a lot of implants, they said, how come you use Straumann? I said, you know what? The Straumann guy comes by every single week. I need that company's support. Some people will say they are industrial strength. They don't restore as well as others. What I mean by they don't have as many options. They do now, bone level. But for me, if you ask me tomorrow what implant I would want in my own mouth or my wife Tessa's mouth, it's going to be SLA. It's going to be Straumann.
And I just want to say one thing on Straumann. They are #1 in units sold. They sell more implants. And what I also found interesting about them, when I asked the CEOs of implant companies to come on, they run. Marco Godolo was on episode number 839, had 1,000 views just on YouTube. That guy, I said, really, you want to come on? I was giving a lecture, and I said, you're going to take questions from he said, I want to hear from my customers. I want to hear from dentists, good or bad. So the most successful people in the world make a religion out of availability. Gordon Christensen is absolutely the modern day living GV Black, and he's come on this show 4 times. And you know what you call some of these CEOs of Smiles Direct Club and Invisalign, and they run the other way. And so kudos to Marco Godola for coming on the show. And he took some tough questions. And from Canada, of all places. I thought that'd be the nicest crowd in the world, and the Canadians were actually feisty up there. I want to go back to Dr. Oz real quick. You always lecture about Dr. Lowe's repair technique. Why?
Well,
explain what that is.
Well, Dr. Lowe can probably explain a little better, but there's really 5 or 6 steps, and you use 2 different tips. And one's a radial firing tip. You use that for the majority of the procedure. It basically lays the plaque, if you want to call it a plaque, down to the bone. You'll then degranulate the tissue. You'll also then use the radial firing tip. As Dr. Law said, there's many different ways to remove calculus, and erbium laser is one of them. But he suggests using some sort of hygiene scaler, whatever works for you. And then he goes back with again, this is his repair system we're using. And again, the nice thing is all on the touch screen. Just go from one step to the next, and actually open up the dental tubules, because really what we're trying to get is that long epithelial attachment. As he said, if we don't open up those dental tubules, that can be a problem. We may not be able to get that attachment.
Can I just give you some advice on Dr. Lowe's repair technique?
Yeah.
If you Google Dr. Lowe's repair techniques, you just pull up a bunch of pages of hernia repairs. So you need to add the word Samuel because...
No, Howard, I am doing that too.
I was going to say, I think the laser might do that, Howard. It could.
I'm expanding my resources, Howard.
And one last time, what was the brand of Straumann that you recommended?
Oh, no, it's Straumann. I'm just talking about their patented SLA surface.
Oh, so any Straumann with the SLA surface?
Exactly.
Or do they all have the SLA surface?
Yeah. Yeah, that is a great surface for osseointegration, for predictability. And by the way, we've used the laser on many different lasers and many surfaces just to make sure it is appropriate for them.
Well, I can't believe we went over an hour, and I'm sure you guys got better things to do than talk to me longer than you have to. But I would say that of all the 10 specialties, don't you think periodontics has changed more than ortho, endo, pediatric dentistry, or public health? Don't you think that specialty has changed the most in the last 3 decades?
Well, you want some more candor?
Yeah.
Because I was with perio residents this morning. Do you know what the average percent of periodontist, a periodontist work week, do you know what percent of their work week is actually doing managing periodontitis?
How much?
30%. You see the problem? 30%.
I get it.
You know what they're doing the other 70? They're placing implants and doing mucogingival procedures. 30%. Now, how did that happen? It happened because of trending. I could go into it. But you know the problem? Periodontists should be managing periodontitis and saving some teeth. And that's what we want to change.
I so strongly agree with that. I one of the Chicago midwinters a few years ago, I had a bunch of periodontists, and I was chastised by them because I said almost exactly what you said. One guy got up and said, "I do perio." And I said, "Congratulations. We need to be saving teeth." If we look at the overall life of occlusion and chewing, we start out with teeth. We get a few restorations. They gradually go into crowns. You start doing some endo. You start jerking some teeth out. And gradually you get into the necessity to do the last resort. Not the first resort, which we're seeing on a lot of offices right now, a little unethically. But the last resort is the implant. It should not be the first resort. It should be we should be saving teeth first. And I'm finding that's a gross need in dental education at the moment. There's more excitement to bore a hole in bone and screw a screw in than there is apparently to place a class 2 resin or a good crown. We need to get back to basics.
Well, gentlemen, before you go, these millennials like to Google YouTube and watch an hour course before they go off and make money and fly across the country and go see you guys lectures. We put up 446 1-hour online CE courses, and it says they've been viewed 482,676 times, so 500,000 times. But those 500,000 are the views of the 446 posted. We've been putting courses up since 2005, but most of them are taken down after 3 years. We've had over 1 million views if you left all the old courses up, but they love that 1-hour view. And the Pankey Institute, they have a week-long curriculum, so they put up an hour course to explain each week. They said it was the best marketing they've done. I'd love to have you guys each put a course up there. It had so much prestige at Dental Town. It transfers so much knowledge, but then it turned people on to you. And that's why I do these podcasts, because I think in the 32 years I've been a dentist, that if I had to look at the number one variable associated to who had a most successful career, meaning they were happy, they enjoyed dentistry, they didn't burn out, they had money, I think it's connected to number of hours of CE. If you're taking 100 hours of CE a year, you're exposed to so much knowledge that you're going to figure out a fun way to be successful. And if you're just taking those minimum requirements to get your license redone. So that's why I started this podcast. I thought, okay, you got an hour commute to work. You're out in the middle of nowhere, Kansas or Iowa, and driving down that highway instead of listening to, talk radio, I'll bring him Gordon, Sam Lau, and Dr. Oz right in their F-150 pickup truck for free. But I hope it'd sure be nice if you guys put an online CE course on this, because when I look out at the dental industry, in America, there's 211,000 Americans with a license to practice dentistry. They build out 117 billion. When you go around the world, there's right at about 2 million dentists. They build out 500 billion for 7.5 billion Homo sapiens. So we know that dentistry is important. I mean, 2 million humans have dedicated their life just to be a dentist and treat these diseases. It's not going away. But when I look at that $500 billion, it's all just kind of growing 1.5%, 2.5%, 3% a year. There's only 2 areas, and this is my last question I want to have you guys weigh in on. There's only 2 areas with double-digit growth, and that's implants and clear aligners. And implants are growing 10, 11, 12% a year. And we just had this Smiles Direct Club, and they just did an IPO, and it was a disaster. And I want to weigh on this because on the one hand, they tried to make orthodontics faster and cheaper, but they decided to go around the orthodontist. Whereas Invisalign chose to incorporate the orthodontist with them. But what did you guys think of the Smiles Direct Club trying to make orthodontics half price by going around the orthodontist? Do you think they were trying to do the right thing by lowering the cost of ortho, or do you think that was just failed, doomed right out of the gate?
Why don't you get a controversial topic? This is so controversial. APAs express their thoughts on it. Orthodontists are hysterical. Patients are doing minimal things adequately well. But as soon as they get into more moderate things, the lawsuits are going to abound over the next while. As I look at this thing, we were the first ones to investigate Invisalign, our CRA then, now it's Clinicians report. By the way, if you want some of our information, let me give you a website, those of you listening. PCCdental.com will get you hundreds of pieces of education. PCCdental.com. If you want research information, you're going to go to Clinicians, it's all with big one long word, cliniciansreport.org. But as we looked at Invisalign years ago, I was very impressed because it was scientifically oriented. They knew how fast they could move a tooth. They knew how fast they could move without degenerating bone. Now, one of the most disagreeable things I see is my patients coming back from some orthodontists where the teeth have been shortened by 3, 4, 5 millimeters for going too fast. There's an enormous amount of information out there about how fast the tooth can move. And when you see that, you got trouble. I'm more than happy to admit that the small amount of tooth movement can be done by almost any human. But as soon as they get a little more complex, somebody has to tell them where to stop. And I don't know who that's going to be.
Yeah, I'd like to just add a few things to that, actually, because I look at x-rays and cases from hundreds of dentists every day as part of my job. And you would be absolutely amazed at when they come into one of our offices, they're doing Smile Direct, and they have abscessed teeth, they have type 4 periodontal issues, they have decay all over the place. I mean, I just don't see how they can move teeth when no one has said that the teeth or tissue is healthy enough to move. That's really what I'm seeing. And I'm seeing it every single day.
Yep.
So, Sam, what do you think about Smiles Direct Club? How's your stock doing in Smiles Direct Club?
Well, the background, there is some link to the other company we've been talking about. The bottom line here is...
What does that mean? What does that mean?
Well, I mean, there was a relationship between Align and Smile Direct.
Right.
And so my point is that, commercial is commercial is commercial. What we're doing is we're falling into the trap of allowing patients to dictate where we're going. And we need to be the drivers of that instead of our patients being the drivers of that. Patients want to, Howard, I have Sam's, there are Maslow's 7 human needs. I'm going to give you Sam's 5 patient needs. You ready?
I am.
They don't want to pay. 2, they want to look fantastic, even if they're a Medicaid patient. 3, they want everything done now. 4, don't hurt them. And 5, they want convenience. So those are the things they want. Our position is to at least listen to the things they want, but not give them what they want. Do I believe that you're going to be able to go into Walmart and get your teeth cleaned? Yes. Do I believe we're going to be able to stop that? No. Do I believe that there was an optometrist that really loved me and took care of me? Yes. Can I find him now? No. Did I know that there was a pharmacist that actually knew my family? Yes. Is there a pharmacist now? No. My physician is owned by a hospital corporation. But I would suggest to you, and maybe it is not, I do strongly believe Jim Pride said this, Dr. LD said this, there will always be patients who want us. And that is the patients that I want. And as long as that occurs, there is still, you know, I just did a review, I interview with U.S. News and World Report. And they said, is dentistry still that dream profession? And I said, absolutely. It's one of the few things out there where you can have a relationship with a patient, be independent, provide high quality of care. So there is a future out there. But if you look at Smile Direct, it's not going to just be Smile Direct, Howard. You know that you can get veneers right now online. They'll send you the impression material. You sink your teeth into it, and you can get veneers. Now, it's going to look like Halloween, but you can still get veneer. My point is, we can't let patient sentiment dictate where this profession is going.
All right. So should we call this podcast Peri Implantitis Treatment with Dr. Samuel B. Lowe, Dr. Jordan J. Christian, and Dr. Ozzie T. Klemma? Does that sound like a good title?
That sounds great.
All right. Hey, it was a huge, huge honor to have you three legends on the show today. Thank you so much for coming on and talking to my homies. It was just an honor to have you guys on. And thank you for your candid, honest, trustworthy thoughts and opinions on all things peri implantitis.
Thank you.
Thanks, Howard. And thanks, Oz. Thanks, Gordon, for being on this. I really, really appreciate it. It's definitely an honor to be with all of you.